The next person I'd like to introduce is Anna Goldenberg. So Anna is at Sick Kids up in Toronto. She is the co-chair of the AI and Medicine Initiative and has a chair position as the Varma Family Chair in Medical Informatics and Artificial Intelligence. So we're excited to have her today to talk a little bit about some of the stuff going on there.
So thank you very much for inviting me. Today, I have to say that I can talk for weeks nonstop about deploying AI in healthcare. So given 10 minutes is a true torture. So I will talk to you about one example that we have running in sort of silent trial automatically right now. And all right, so this is an operational question that we tackled. The plan was to figure out staff and resource management in an emergency department at Sick Kids, which is a pediatric hospital here in Toronto. And there's basically already a procedure in place where if we have about under 30 patients is okay, but at 30, we are transitioning to escalation level 1, where we are about at 80 to 100% inpatient beds. So administrators have to be contacted to allocate more space. And 30 to 37 is this level 1. Then the escalation goes to trying to figure out how to procure extra space, discharging faster sort of onboarding faster as well. And then at the highest level, it's basically we have to open another clinic, have to put maybe accept some patient as an inpatient. So it's a very actionable sort of question. And the task for the machine learners was for our team at AIM, AI in Medicine, was to figure out how to make a 24-hour forecast for the next day. To see what the expected number of and the range of patients will be, so that the emergency department can plan their resources and management. So this is our data. We used the date, the number of arrivals per hour for the last 24 hours, the census, which is the number of patients currently in the unit for each hour for the last 24 hours. For training, we had about 202,000 patients from June 2018. And you can see here is basically the patient volume displayed for the period of training. And you can see that there was sort of a pattern until COVID hit. And around January was the highest volume. In January 2020 was 140 patients as the census. But as COVID came, there were policies and procedures that were put in place, which reduced the number of patients significantly. So people were expecting a lot of patients to come in with COVID. So there were procedures that were put in place. Plus, some of the parents chose not to come to the hospital, not to be exposed. And so the numbers really went down. And you can see that they're picking up, they started picking up sort of post-May, but are still much lower than you would normally expect in a pediatric hospital. So the development cycle may be similar to a research development cycle. We tried the linear to regressive models, completely failed at COVID. They just stopped and didn't really work because of the non-stationarity of the data. We tried the locally weighted models sort of within windows, performed a bit better. We then used Gaussian processes also within smaller training windows, sort of moving windows. They performed better until we discovered that we were using some of the data. There was sort of this data leakage. So we discovered that we were using some of the data that was recorded after the model would have to have run. And so once we adjusted for that, we actually got a little bit worse results, but you can see the root mean squared error here. The Gaussian process models did perform the best. So the current model that is running right now in emergency department in a silent mode in parallel to clinical practice is estimating each hour using XGBoost and then smoothing using Gaussian processes. And what it allows us is to provide uncertainties on the estimates and provide a sort of a single smooth estimate per hour, which is very nice. What I want to tell you, the important part is that the time of day is probably one of the most significant feature that we have. So the baseline is basically the time of day, and you can see that the red, which is our model, is following pretty closely, but it still performs better. And of course, you don't want to, alert and plan for much more staff or something like that if there is no need. So predicting these numbers within the proper ranges is important. So there are several things that people sometimes choose without necessarily justifying why. And when we are preparing a model for deployment, we sort of have to be sure and know why we chose certain parameters. So one of the parameters that we had to choose was how often to retrain the model. So this is not one of those settings where we could just develop a model and put it in practice and then, in the background sort of retrain. And this model is being retrained every night and tested every night. And this is the next 24 hours are being predicted with a model, with a new model. So this was a parameter that we have determined, and you can see here that the precision goes really way up if you retrain every night, and it sort of, if you use 2 or more days, the precision just drops. So another parameter that we looked at that we had to figure out is how many days to train on, how much data to train on, right? We had 2 years of data roughly, and for the most recent data, at least this summer. And so what we looked at is, can we train these models on less data or can we train it on more data? And of course, since there is periodicity in this data, at least to some extent, 1 year turned out to be the best predictor for using the precision metric that we've been using. Interestingly, if you use more data, it just adds noise to the model, so the performance deteriorates. And this is something important, right? Because in machine learning, we say, oh, we want the most possible data. But the reality is with COVID, especially, the more data, the more noise you add as well, with respect to your current time and observations. And finally, another parameter that we looked at was how many days to use for validation. So this is your x-axis is number of validation days. And this means that the training stops 2 days before, and the last 2 days are used for validation of the model. And this is what model is being used to predict the next 24 hours. So if we stop way before, again, due to some of the non-stationarity, we perform worse. So we found that stopping 1 or 2 days before gives us the best performance. So we use 2 days. So the important part, and I think this goes back to the discussion that was just had by the panelists, important sort of part is the calibration of the model. And for us, so Eric Drysdale, who was developing this model, he looked at the theory of how to pick a threshold for each of the models and visualizing it as a random variable, and sort of thinking of it as a random variable gives us a chance to figure out what the threshold should be and how to calculate it for each of the models automatically going forward. And what we have figured out is that for 80% precision, which was our target, we set the threshold at 10% false positive rate, which was given us the targeted performance. And you can see some of the performance here. This is the forecasting horizon for one of the days. So training period 1 year, validation 2 days, retraining nightly. And you can see that we are performing better than we would have anticipated. The precision is higher at almost all the hours, except for the sort of the tail. It deteriorates at the tail of the last few hours. I will try to run this video. It was not behaving properly when I tested it. So, but the point is that these are observed points of how many patients you see. And this is the model that is fit. And this is something that follows the model pretty carefully. And since it's being re-estimated all the time, we sort of have some confidence that we can provide to the clinicians that this is the performance they should be expecting. So this is the video is a little bit choppy, but basically this is the visualization we can provide to the clinicians to take a look at the performance of the model going forward. So some of the lessons learned, it is incredibly important to set up the evaluation in the exact way that the model will be deployed, right? Because it's so easy to just have a little bit of leakage, right? Relying on some piece of information that may be recorded after, but in principle should be recorded before. But this is not how nurses operate. And I think that it's critical to make sure that the model is in touch with the clinical workflow at the moment and using only the data that's available to it. And evaluate it prospectively. So most of us know this, but it's amazing that even in our work, and we do it all the time, and sometimes it's this kind of things seep in. So one of the anecdotes, actually, I can say that happened with the daylight changing time. So Epic doesn't record the Unix time, it records a regular time. And in Epic, the records are stored. So for 1 a.m., you would have the record that was 1 a.m. And then after you change the time, you have another 1 a.m. record. I don't know if you've noticed this or not in your applications, but some of the sort of machine learning tools that rely on time, they say they throw up an exception flag. They say this doesn't look right. You have two different reports for exactly the same time. I suspend my activity. And so this is something that all of our applications right now, we're using the sort of the Unix standard epoch times from January 1st, 1917, and it doesn't matter whether it's daylight savings or not. But it's a kind of thing that if you rely on Epic data and how they encode it, sometimes you are subject to this, to these things. Retraining validation matter. Sometimes how you break down, like how regular or irregular your measurements are. So we picked hourly, and when you record that matters to the performance and to the model. So you have to be sort of careful about that. And in our case, it was really interesting that we brought this back to the clinicians, and we were working with the clinicians the whole time, but we were working with a doctor in the emergency department. And when we started talking to the nurses who would actually be using this app, they said, wait a minute, we have all these other interesting questions that we would want you to answer. And so I would say that if the ultimate user of your apps would be the nurses, then engage them early to see what their desiderata is. And there are tons of other lessons. And finally, I just want to say that we were very inspired by CT's song. And so we wrote the limerick, Eric and I, and just wanted to share it with you. This is much shorter, but it was written after the talk. So there once was an ED medic who wanted patient numbers from Epic. COVID having interfered, updated AI nonetheless persevered for the children to be treated unhectic. This is our contribution, and I want to thank AI in Medicine program, Eric very much so, and my lab and the funders. Thank you.